Buenas tardes.
Good afternoon and welcome. Thank you for participating to this third edition of the Spanish National Pompe Pompe Patient Association. Many people have hopes. We have relatives, we have medical professionals, and people from research with us here today. This is an occasion to continue to address the daily needs and the importance of the multidisciplinary approach for the affected person, and doors open for research to make a cure a reality. For these next 2 days, we will all be here, and we have each speaker so important and necessary in the project to improve the lives of people who have Pompe disease. This conference gives us a new opportunity to underscore the fact that from the association, and in this case from our own small but active association, we work very hard to be the voice of the affected people, and we need help for this. To organize a conference such as this, which we are inaugurating, is to address research, medical developments, therapeutic approach, and of course the life histories of the people who have this, and as well as what their relatives say. I would like to state that these meetings are a need. But to organize a conference such as this with continuity in time is a huge effort for an association like ours. We are small but very active. We wish to continue, and I am saying this, we wish to push forward, and this is why this is a moment for claims. I said before that we need help, and this is a fact. We are associates. We need initiatives which will help us to generate resources from the institutions, from entities, from the pharmaceutical industry, and from enterprises, so they have a social responsibility, and also we need the help from the third sector. If we are able to work all together, we shall be able to be a voice and support to accompany and to help to be a small but active association. I wish to give special thanks to all of the people involved in the organization of this meeting, its development, and to the professionals who are with us, to the speakers who shed light upon this disease. Thank you for continue confiding in Pompe, and we are going to be together, and we shall continue to write the history of Pompe, Spain. And for these 2 days, we will hope that they will be more. This will go to the future. This is a prelude for many more conferences. Thank you very much.
A continuación.
And next, Juan Carrión has the floor. He is the president of the Spanish Federation of Rare Diseases, FEDER, and he is going to give a virtual presentation. Thank you very much. Thank you very much for the invitation extended to the Spanish Federation of Rare Diseases to participate in the third edition of your conference of the Spanish Pompe Patient Association. I can't be with you personally today as I would have liked to, but I would like to give you all the support to your Spanish Pompe Patient Association. And dear Alejandra, President of the Spanish Pompe Patient Association, to your team, congratulations, of course, to you and your team for having organized this conference, which will enable us to learn so much and to share information with different professionals. We have researchers, we have research, and the patients and the relatives. We will all learn from one another, and we know that this is something that all brings us together when we speak about rare diseases and infrequent diseases. And I would like to thank Manuel from the Spanish Federation of Neuromuscular Diseases, ASEM, because we know that you've worked very hard. And by the way, I know that in a few weeks you're going to celebrate your 20th birthday. I would like to tell you how thankful I am for what you do. And I know that you're all going to be participating during this 2-day period, And you're going to be learning so much, which the Spanish Pompe Patient Association has prepared and what we will learn from. And we're going to be able to share these issues and challenges that we all face. And we know how difficult it is to diagnose these rare diseases. And particularly Pompe disease is always very difficult to diagnose, and we want to continue to share what is coming from research and so forth. We have new therapies, and we must go forward and progress, of course, because we also have to have hope. All of these patients must have hope, and when we have an orphan drug, we want it to be available to us, and we need to have access to these orphan drugs. So in a nutshell, this is a big challenge that we have as a federation, and we need to all together defend before the administrations, defend our needs, because ours are yours and yours are our needs. And this is something, as I say, we should do together. And of course, for me and for all of those who are in this large group of people with rare diseases, and in Spain, we're more than 3 million people with rare diseases, and we know what it means and how important it is to invest money in research. This is the future and hope for anyone who lives with one of these more than 6,152 rare diseases that for the moment have been identified. Congratulations to the Spanish Pompe Patient Association, to each and every one of these people who are part of this group, and for the work, the extraordinary work that you do. And I would like to congratulate you for being able to respond to the needs that these patients have. This is very important to remember this. We, of course, need to be able to speak about the future and have a future with hope for all of us, for each and every one of us, to be able to witness what is going on. And we see that there are many important announcements made lately in our country about, well, there are better public health policies to improve the lives of our people. This is something that we can feel, and it will, of course, bring us a brighter future. And, of course, we know that we need to feel those results. This is something we actually kind of can touch, shall I say. And we work together so that everything will be a reality. And we want to make the most of all of this information and knowledge. And I know, as I say, you're going to make the most of everything that we learn here from our extraordinary speakers who are going to enlighten us. And from the Spanish Federation of Rare Diseases, this huge family with more than 420 organizations in the country, that we will be by your side in order to be able to share our knowledge and, of course, to continue walking this path together.
Para concluir,
To conclude this inauguration ceremony, we shall give the floor virtually to Manuel Rego. He is the president of ASEM, the Spanish Federation of Neuromuscular Diseases. Hello, one and all. Hello, one and all. In the first place, I would like to address the organization and, above all, the president of the association, and to thank her for having invited me to participate in this inauguration ceremony, although for now this is virtually. I'm sure that in future occasions we will be able to meet in person. In order to be with you in this inauguration ceremony of your conference for the ASEM Federation, the Spanish Federation of Neuromuscular Diseases, as I say, it's very important, and we wish to share important moments for you and for us. These are associations, and which is, in other words, the organization of your conference. This is a conference which has an extraordinary program prepared for everyone. And also, I would like to congratulate you for your objective, your aim, which is so clear and so necessary. The aim is to bring together researchers with the patients. Research which on many occasions forgets about the most important part, which is the patient, the person, in other words, for whom research is being done. And it is vital for that person to have this research and these developments. And sometimes we are forgotten about, left in a corner, as if we were just a little statue cast off into the corner as a decoration, when in fact we are the most important part of all, because research for a patient without the patient does not progress. It doesn't move forward. It helps no one. So we know about our disease better than anybody. We are familiar with the symptoms. Some are affected more, some are less so. But no one knows more about this, even though we see a lot about this in textbooks, because we, the patients, are the ones who feel this in our own skin. And this is why it is extremely important that the researcher meet the patient in person. Personally, this is why I'd like to congratulate you for your objective, your aim, because this is a singular space and an opportunity, which I do hope there are many of these, and that you will have research that will go hand in hand with the patients and with associations which represent the patients, because this is an important moment to go ahead and to go hand in hand, as I've been saying, to join forces, in other words. We need to walk together, as the ASEM Association said and the Pompe Patient Association said. We need to stride ahead together. We need to knock down the huge walls which we find along the way, those of us who have a neuromuscular disease in Spain or disorder. And so we've been, well, actually, we've been on the 17th day of November. It will be our 20th anniversary of working, and we have a long way to go. But personally and hand in hand, we can do this together. The Spanish Federation of Neuromuscular Diseases began working as an association, and then it was changed into the Spanish Federation of Neuromuscular Diseases. So that's been 20 years now. The 17th of November is our anniversary, and this is a very special anniversary for us because throughout this 20-year period, we have gone through many turning points, and we, above all, in this last period, we've lived a series of external circumstances which have complicated our lives for patients' associations, of course, more so with people. We've had pandemics, and at the moment a war, and this has a repercussion on everything, because sometimes it means that patients are forgotten about, the vital function which we associations, patient associations do, and the Spanish Federation of Neuromuscular Diseases works every single day to try to make the work visible, this wonderful work that is done by your 32 entities. We need to make this visible, as I say, and thanks to which we have been knocking down walls. But as I said, we have many other walls to knock down, obstacles to overcome, and we have basic rights that should be recognized, to have that we have access to continuous physiotherapy programs, that we have good assessing of the degree of dependence, and as I've been saying, it's important to have a quick diagnosis and an efficient diagnosis, and this would certainly facilitate the way we can cope with our diseases, and we could plan our future as persons, and above all, to be able to be familiar with our disease and to make more progress, and that we can walk hand in hand in this future, and with our progress that will undoubtedly occur. And as I say, there will certainly be, in this 20-year period, we've grown and we've moved forward, and with our Spanish Federation of Neuromuscular Disorders and also our Spanish Pompe Patient Association, we work together. We're all making significant progress, and we're going to progress and move forward together. Thank you very much for being part of the Spanish Federation of Neuromuscular Disease group. Well, thank you very much once again for all being here, and this third conference for Pompe disease patients stands inaugurated. We shall begin our program with the round table that we call respiratory involvement in Pompe disease. You know that early onset respiratory problems, our muscles are weakened, and the alteration of coughing leading to pneumonia, repetition pneumonia. This also affects swallowing, causes apnea, lethargy, snoring, and other things. How do we approach respiratory involvement in Pompe? And respiratory failure as the main cause for morbidity and mortality. And where are we to approach these respiratory infections in Pompe? We now welcome Dr. Barbara Smith from Florida University, and she will chair this session with the participation of Dr. Ana Hernández from the 12th of Octubre University Hospital and Dr. Jesus Sancho from the University Clinical Hospital in Valencia. Thank you to the three of you, and you may come up to the table. Thank you.
All right, thank you very much for the opportunity to join you here at the third Congreso. You know, I can't say any of those words up there, right? Thank you. I really appreciate the opportunity to be here with you from Florida and to join two experts, one from Valencia, one from Madrid, and their research and their clinical expertise that they provide in Pompe disease. And so perhaps first, maybe each of you can share a little bit about what you're working on, the care that you're providing, and your interests. Is that okay?
Yes, hello. I would like to thank the organization for this invitation. Thank you very much. Well, I am a pneumologist from the mechanical ventilation unit of the 12th of Octubre Hospital in Madrid. It's a usual reference center of neuromuscular pathologies and with Pompe patients as well. We dedicate mainly to respiratory support with mechanical ventilation, but we also have several research lines with respect to this pathology specifically. Well, good afternoon. I also would like to thank for this invitation to be able to be in this Congress. I'm Jesus Sancho. I'm the coordinator of I'm pneumologist as well. I'm the coordinator of the respiratory care in the pneumology hospital of the clinical hospital in Valencia. It's a reference unit that in the Valencian community for managing the respiratory problems at large in neuromuscular diseases. Our work is focused mainly on the control and the management of the respiratory problems in general of the neuromuscular diseases, and we also include patients with Pompe disease.
Thank you both. And so Ana and Jesus, we discussed in advance of the conference how best to coordinate the roundtable discussion, and really felt maybe more of a conversational tone might be the best. I think Manuel just said it very nicely, right? That our participants here in the conference, you're not statues in the corner, right? You are the experts in your own living condition. You are our partners and our stakeholders, both in research and in clinical care. And so we've come up with a list of things that we think maybe are vital to the patients that we work with. We'll discuss some of those factors, but we also welcome some conversation. The first thing that we'll go to is discussing the topic of sleep. And of course, we spend almost a third of our life sleeping, so it's sort of an important thing for all of us. And in many instances, the symptoms of respiratory insufficiency first become apparent as problems with sleeping, and we want to acknowledge that and maybe discuss a little bit why sleep can be problematic for people with Pompe disease. So would either of you like to maybe elaborate on why sleep might become a problem?
Sí, bueno, a ver,
Yes. The patient with Pompe disease is particularly complex as to the sleep pathology is concerned. It adds something more to the traditional sleep pathology. Well, usually, nor Jesus nor myself dedicate exclusively to sleep, but we nevertheless have patients with Pompe disease that in turn have sleep disorders. In Pompe disease, the peculiarity is that apart from the diaphragmatic involvement, that is also what is most concerning for us, this is the first cause of death, is the respiratory failure in Pompe disease. And this is in reality what we dedicate much more time. The patient with Pompe disease is more complex because not only does it involve the respiratory musculature, but it can also produce weakness of the oropharyngeal musculature. And that's why having weakness in the oropharyngeal musculature, it can be a sleep apnea syndrome, as is the usual one. This is an obstructive sleep apnea disorder, most of the syndromes that exist right now in sleep apnea. But apart from that, in Pompe, it has also been proven that there can be involvement of respiratory centers at the central level. So there can be obstructive sleep apnea, the classical one, but also central apnea of the sleep that is harder to manage. Apart from the fact that it can be a sleep obstructive apnea due to weakness of the oropharyngeal musculature and collapse when we are very fast asleep, and central apnea of sleep, that is because the neurons of the central drive of the respiratory center do not issue the signal of breathing during sleep. And also the peculiarity of the macroglossia adds another problem, added problem. Sometimes there are obstructive sleep pathologies not due to weakness of the pharyngeal musculature, but due to a macroglossia, especially when the patients are lying in prone supine decubitus when there is more obstruction. So the sleep pathology in patients with Pompe disease is quite more complex than mere sleep apnea syndrome. That is the usual thing that we see. And we have several problems in managing it as well. I don't know what your experience is, Jesus. Well, practically what you have said, and I just would like to add something. Not only in the obstructive sleep apnea, but if we focus on the problem of the diaphragm, the main muscle that is will be involved by the Pompe disease at the respiratory level, the main signs or repercussions are going to be on sleep, although the patient is asymptomatic at daytime. In general, everybody during sleep breathes less. There is an alternating of phases throughout the sleep, and there are specific phases where the activity of the breathing depends only on the diaphragm. In patients where there is a weakness of the diaphragmatic muscle, as is the case of Pompe disease, this is going to make that during that phase of the sleep, the diaphragm doesn't have enough strength to work as it should and produces what is called, apart from the obstructive sleep apneas, pictures of hypoventilation. There is low oxygen in the blood, and the carbohydrate starts rising when the patient wakes up until the disease is not more advanced. We don't see the symptom derived from that problem, from the respiratory involvement. But in many patients, long before, we do have those problems at nighttime. So it is very important, and hence the endeavor, especially done by the studies made by Anna with different techniques to detect on an early phase this involvement of the respiratory muscle, because as she said, the patients during the daytime are asymptomatic and they say, oh, I'm breathing well. But you make a study at nighttime, during the night, how he breathes, and we see that the problems may starting appearing.
Thank you. We know that some of our participants have in their pulmonary care have received sleep evaluations. Others have waited a considerable time to receive a sleep evaluation. And just, I wonder if you can comment a little bit about maybe clinical tests or some of the research that you're doing that might cause a provider to detect that there could be a problem and to prescribe a sleep evaluation, and what that process is like.
I have several slides I'd like to show you, if I may, concerning the results.
No sé cómo... ya vale, perfecto, ya está. A ver si abro aquí. Es corto, prometo no extenderme. Pero...
This is short. I won't go on. This won't go on long. And we've already heard frequently that respiratory involvement, as we heard at the beginning, and as we already know, that this respiratory involvement in Pompe disease is the first cause of death, with which it makes quite a lot of sense to get a clear diagnosis and then firstly evaluate the respiratory musculature, because this will determine acute respiratory failure, which is the main cause of death, and besides, it is the main cause of hospitalizations with respiratory infections arising and things like that. And I think this is quite important here. So let us look at the respiratory musculature. The neurologists, in this sense, have the problem because the tools available to us are not sensitive enough. This is it's a revision from different respiratory functional tests in patients with Pompe disease. And if you look here on the left-hand side, you see the spirometry, etc. You can see all the tests that we do. And within this little red rectangle, you will see on the left-hand side the sensitivity to these tests, which is quite low. And on the right, the specificity. What does this mean? It means that when a patient does these respiratory functional tests and when they're done not so well, they won't be very good. But a lot of patients aren't very well. They do not have changed results, and one might not detect a respiratory involvement in time in order to begin adequate treatment. So this is what Jesus was mentioning. Here we need to find tests and find proof that not necessarily more specific, because the ones that we have are already specific, but they must be more sensitive. In this sense, we have a study developed where this is being carried out in the 12th of Octubre hospital, our hospital, and this is a follow-up of a series of Pompe patients with respiratory problems. We do this every 6 months, but we add a bit more. Specifically, we add, this is the SNP and also capnography transcutaneously. And these are novel, they are sensitive, and these detect high alveolar hypoventilation, as Jesus said. And tomorrow, if you can do these tests, I'll explain this in person and in greater depth. And look at the muscle here. And then you see a video of how the diaphragm thickens. If those of you aren't too familiar, but I'll explain this in greater depth. Tomorrow, thickened diaphragm. And this is very interesting here. And during this follow-up, as been described in this entire series, there's a progressive decrease of the FVC. That's the most important. We know that the forced vital capacity is very important. That we need that this is very important. When he's lying down, it increases. But when we've seen in this particular series, as that the SNP is a specific test, as the fraction which the ultrasound gives, and it drops before 6 months beforehand, before is done. And when we see this in the FVC, forced vital capacity. And so we suspect that these would be more sensitive techniques in this sense. I wanted to complement something Anna said. Most of the studies made not only to assess the respiratory involvement and problems of Pompe patients and their disease, but see the efficacy of the drugs. And so these tests that Anna spoke about are used. We have the vital capacity. It's important to do, but when it's altered, the patients they've already evolved, and we don't detect all of those patients where there might be an involvement of the respiratory muscles, and with which I would think that the study should focus on more specific tests to detect much more early on the respiratory involvement and to see the efficacy of the different treatments that are being developed for Pompe disease and to see the results on respiratory function. Perhaps this will explain the results that we have, for example, when we give a substitution therapy, enzyme substitution therapy, replacement therapy, and most of the studies say, oh, it's stable, it's stable. We don't know if any. Others say it improves, others it worsens. Well, we're going to have to, maybe if we had more sensitive tests, then we would see the repercussion that it really would have on the respiratory musculature.
About this, in that the tests that sometimes accompany a scientific study or a clinical trial are not necessarily reflective of what the respiratory muscles do every few seconds when we don't think about it. These tests are maximal effort, they're effort dependent, they're learning dependent, and so indeed, I think looking more closly at what the respiratory muscles are doing naturally, whether while awake or as discussing while our patients are asleep, and whether the ventilation is sufficient during that time. They're telling us maybe two different things, and maybe we need to take a closer look at both of those things and not just one.
Sí, probablemente es mucho.
Yes, surely. We don't try to do away with spirometry. It's a very specific technique. It's been described and used for a long time now. But it is true that spirometry is done when the patient is sitting down, awake, completely awake. So for someone yelling at you, do this, do that. So it's not the same situation that a patient might have during that person's sleep. It doesn't really make much sense. Not only we should, to diagnose the respiratory involvement, and as Sue says, monitor the response to the treatment, and if it has to be sensitive, because maybe the problem isn't with the treatment, but in the tool that we use to measure the response. In fact, in our daily practice, when we see patients, not only do we evaluate them using spirometry, but also we use many other techniques, which as a whole will give us information about the true, real situation of the parents from the patient's own symptoms, that spirometry, obviously vital capacity, in decubitus, muscle situation, ultrasound. This is being used now in all of the practice of pneumology, and this is a very valuable tool for us. And at nighttime, we need to have possibilities to do this at home, thanks to different companies that supply this. And so we don't necessarily, in the past we had to put a lot of cables on the patient and wires and all to make these measurements, but now it's easier done at home. And now a very important aspect would be the muscles, which will enable us to take the mucus out. Because if these muscles don't work well, just a mere cold will cause problems. It's this mere cold, Well, if this person with a cold and goes onto the street and a person with Pompe disease, it could cause claudication. That person would go into the ICU with respiratory failure because that patient couldn't bring out his or her secretions. So it's very important to evaluate the capacity that those muscles the respiratory muscles have to be able to allow a person to cough, to allow that person to expulse that mucus when a person would have a cold, for example.
Now, the scientific literature, I want to ask this question because this has come up a few times, even just this year. The literature indicates, of course, using ventilator support is a balance. Really too little will not correct our hypoventilation. It will not support central apneas. But on the other hand, excessive settings may make the patients feel that their natural breathing is not synchronized. And that can create disruptions. So when the prescribed settings match the patient's need, it helps to promote the deeper sleep, prevent hyperventilation. And so what is your approach to making sure your patients are comfortable? And what symptoms should warn patients that they may need to speak to their physician about adjusting their ventilator settings?
Bueno, para empezar.
Well, to begin, the patient with neuromuscular disease, particularly Pompe disease, is never far from the pneumologist. That person always is seeing a pneumologist and usually sees the same team. Once the respiratory failure has been defined and it needs support with BPAP, it's not given that. BPAP must be titrated, and it must be retitrated whenever it's necessary. Whenever it is necessary, it's important because it's not a static device, but when the disease progresses, and it will progress with age and weight changes and so forth, then we must monitor, reprogram that respiratory device. So there are simple things that we can do. For example, patients with Pompe disease, even though they are being treated with BPAP, they need to follow functional tests. They need to do the functional test, the respiratory functional test, because not only do we detect this when they need the BPAP, but we need to see how the rhythm here. In each review, we have a tool, and it's simple. It's this respiratory software. And I would like to say that in Spain, Jesus, correct me if I'm mistaken, we review the software of the respirators, that this monitors the flow and pressure curves the patient makes. We see this in our office, and we can see how the patient is breathing, and we can quantify the volume of air going in, the pressure going in, if the air escapes, and so forth, even if the person wears this device. And this could be monitored continuously. And there are degrees of monitoring which are sometimes more complex depending upon what the patient needs. The last degree of monitoring is that sometimes it's necessary to the patient should go into the hospital to use electromyography, esophageal probes, and more advanced types of devices to monitor this. We don't not only indicate ventilation, but also we have to see if the patient, in fact, has efficient or deficient alveolar function during the night. If there's any incidents, the patient must call. Sometimes if the patient is sleepy during the daytime when that patient was not sleepy beforehand, because this might mean that the disease has progressed and now the patient needs more pressure, or air is being expelled, there are leaks, and enough air is not going into the lungs. But regardless of the fact that the patient has symptoms or not, the follow-up should always be continuously done, even in patients who are asymptomatic. I would like to add an important thing that Anna mentioned, and that we see the ventilators and we need to correct the parameters because of one very important thing, because the disease progresses. And it might be that during the night the ventilator is okay, but the problem be that the disease has progressed, the weakness of the respiratory muscles is greater. And so what the patient, in fact, needs is not only to use the ventilator at nighttime, but also to use it during the daytime. And here there are different ways to send air using different types of masks so that we be able to help, and in very advanced phases, we be able to substitute the respiratory muscles when the disease is already very advanced, and during the daytime the patient is not able to even breathe correctly.
Okay, thank you. You mentioned transitioning maybe more into some use during the daytime and maybe some different options with how support during the daytime is addressed. In your experience in Spain, there's some use of this in the United States. What is your approach with using devices to improve recruitment of the lungs, the lung volume recruitment here in Spain? Is that something that you can comment on?
What you said is very interesting, because this is another problem that we have when there is weakness of the respiratory muscles. Under normal conditions, everybody, without even realizing this, every single day we breathe in. We breathe in and our lungs are completely filled. We don't even realize this, but we filled our lungs up maximum, laughing, coughing. This enables us to maintain the lung elasticity of the lungs and the chest. Let us take a balloon, which children use. We will leave it a few months without blowing it up. We just leave it on the table. Then we take it, we try to blow it up, and we cannot because it's stiff. And with the chest and the lungs, the very same thing happens, with which, as she said, there are a series of pulmonary recruitment techniques enabling us to get the maximum capacity of breathing in order to maintain the elasticity of the lung tissue as well as the chest and the joints in the chest cage. And here, in my experience, we use breathing in with the manual resuscitator, and we have different moments of bringing in the air. If the patient cannot fill up his lungs, then artificially we're going to fill that patient's lungs up. We're going to blow them up, in other words, to a max, with which we're maintaining this elasticity. And another technique we use, and this is with the ventilators and with the air from the ventilator, instead of doing this manually with the ventilator and with the mechanically assisted cough, great volumes of air and fill up the lungs to a maximum and have good tissue tone. It's also true, and what's going on here in Spain, what happens in different autonomous community. But we know that in Madrid we have a deficit with public help of respiratory physiotherapy. Our patients, for example, who have physiotherapy, and they should all have this, not only if there is a respiratory involvement, but before there is, in fact, this problem. And in our public hospitals, we don't have enough of this to help us, physiotherapy, and patients have to find physiotherapists who are in private practice or devices, AirFit and different companies. And this is muscle training. And this is monitored by professionals. And there's a great deal of deficit here. I don't know what the air experience in Florida is with this.
Yes, so certainly in the United States, we maybe have different issues with access in healthcare and physiotherapy provision. And so our insurance situation is quite heterogeneous And in many situations, a respiratory physiotherapy is not universally covered by an insurer, which can create some disparity in access to the physiotherapy. With that respect, then prevention and education become paramount with our provider access points, so that patients receive the equipment and the education that they may need, because there may be just short periods where the physiotherapist is able to work with the patient, so that independent routine can be established for patients. And so I think in that respect, finding a routine that is not just of course evidence-based and scientifically recommended, but also feasible for what the patient is able to do, for their resources, and not just financial resources, but their time resources, and what is able to work within not only meeting their respiratory needs, but then the other commitments the patient may have. And so I think that's where we don't always have a lot of time to work with the patient to find that balance. But I think it is crucial to work together to understand what it is the patient might be able to do with respect to committing to preserving, committing to a routine that may help them to preserve their respiratory function.
I think, Ana, that not only in Madrid but also in all of Spain, there's certainly a deficit of physiotherapists. Here in Valencia, we, the pneumologists, are the ones that devote a part of our time to doing the work that the physiotherapists should do, in fact.
Speaking a little bit more about physiotherapy, about exercises, there have been some smaller trials in the literature that indicate respiratory strengthening exercises might help preserve breathing function, both in younger patients as well as individuals with adult onset Pompe disease. And our group has a little experience with this, but I would like to hear about just the use of respiratory strength training in Spain, whether that's something that's accessible to patients or whether other exercise approaches are used maybe to preserve breathing here.
Ese es el problema.
This is the problem. We don't have enough physiotherapists except for very specific programs where there are more investments, and in a neuromuscular area, well, we really don't have enough expert physiotherapists for this. For physiotherapists in our hospital, the pulmonary care in our hospital, there are a series of professionals who help improve the respiratory function of these patients as a bridge to the transplantation. It's not possible for patients with neuromuscular pathologies and for many other patients as well. So unfortunately, our experience is more individual, each patient hires his own respiratory physiotherapist, and that respiratory physiotherapist, well, there aren't so many of them because there are many physiotherapists for the muscle skeletal system, but for lungs and all, they're very few and far between. And what I've heard from my patients who do get good results, they use training devices which are linked to applications they have on their mobile, AeroFit, because not only is this a variable pressure device for inspiratory pressure and diaphragmatic training, but also the app designs a program, a timetable, and charges. They increase the pressure little by little and reminders and this and that. The fact is that these are very specific experiences. Unfortunately, I can't tell you about too many experiences with rehab programs. We would certainly like that, but it's not the case. There's a long way to go here.
All right. Well, it sounds like we just need to get a sabbatical for me to come and join you in Madrid for a year or two. Yes?
You're very
yes? Okay. Wonderful. So now, Jesus, as we prepared for this conference, you brought up an issue that I think is very important, and that is respiratory drive. And, there is evidence that as, respiratory muscles gradually become less effective, that the drive to breathe, can become impaired over time. And that, perhaps asymptomatic Pompe disease, really should be reconsidered, because maybe there are subtle signs that could suggest that our patient is, their disease is progressing. And so some of this overlaps with some of the concepts we've already discussed, but how is this apparent in your work with respect to the asymptomatic patient, and how do you approach the patient who otherwise is ambulating well in the community, is still working and managing their family, but how do we manage and make sure that these subtle signs are not missed?
Como si el paciente está asintomático, ¿cómo podríamos detectar que tiene disminución del drive?
Sí. Pues.
Well, we need to get all of the tests by trying to analyze very carefully asymptomatic patients by looking at the blood gas exchange, and we see the bicarbonate because there might be blood gas exchange, but high bicarbonate, and this is indicating that there are nighttime problems, which mean that the bicarbonate go up at night, and whilst the patient is sleeping, it's different, and when they wakes up, he's normal again, and we can, instead of checking a certain value in a cutoff point to see their vital capacity, I like to see how everything is evolving as time goes by. If there's a sharp drop or just a progressive drop, for example, and to also compare this with measured vital capacity in supine decubitus position. And we look at the diaphragmatic ultrasound because, as we're hearing, this is being introduced in all of the doctor's offices. And if there's a minimum suspicion, we do a nighttime study. Sometimes we can do this at home, these tests at home, and our capnography, as I mentioned before, to see if a patient has, we see what the different, we can see that with this capnography, and as I say, we can see the situation of carbon dioxide at night and day and all. Thank you.
Sí, otra cosa es que
Another thing is, at any rate, even in patients who don't have respiratory and muscular involvement, but they do have involvement of the central drive, these are patients who might have central apneas, and not only are they difficult to diagnose, and for this we need to have polysomnography. This is a sleep study, but also with an EKG, and we can do this we can see that the problem is, the thing is that we don't even have a very effective treatment in this sense. For example, new technologies are being developed, and they're not really too developed yet, but new respirators, and they're servo respirators, and they use a little bit of artificial intelligence to respond to certain stimuli. This is still very, shall we say, we don't know too much about this. We don't know as much as we do with the CPAP, but this is something that is being done. All these respiratory pathologies of central origin are very complex to diagnose, to treat, and to follow up. In Pompe, unfortunately, Pompe is one of these areas. In fact, the possible techniques that we can use to evaluate, to see if there is this that can cause respiratory drought problem. These are problematic to do as well as to interpret. It would be important to be able to go ahead in these topics, these issues, because this drive alteration is something that we find which is interfering with the good functioning of the ventilators when the patient is using the ventilator at nighttime.
Thank you. And something that I've heard come up during our conversation here, a few things about maybe what also alerts you, things that the patient may tell you, such as becoming more sleepy during the daytime. I think we talked about waking up not being restful, maybe having a headache, frequent awakening, not frequent disruptions in the sleep cycle. There was also an interesting study. It was a assessment of Pompe disease, sleep. Several years ago, it was a study came from scientists in Italy. But in addition to these symptoms, they found that patients who are hypoventilating at night also woke up more often and felt, when they awoke, they thought maybe it was perhaps because they needed to use the restroom to empty their bladder. But in fact, it was, they found that those patients who were waking up more frequently to use the restroom had the lower, had the lower ventilation, had more nocturnal hypercapnia. So maybe sometimes we as individuals, as patients, wake up and don't necessarily understand why we've awakened, but that we, in fact, maybe need to discuss that we are just awakening more at night if that's a problem, rather than assume that it's one thing versus another. We also brought up earlier that, of course, effective ventilation is clearly imperative, but another essential role of the respiratory muscles is protecting the airway. And clearing mucus or any other contaminants from the airway. And so in your practice, how do you evaluate cough and make sure that the forces generated to clear the airway are sufficient?
Bueno, esto habitualmente.
Well, this usually, we don't need to ask about this much because this is a very striking for patients, and they usually tell us about this. And for example, they say, I cannot get rid of my mucus, and even the wife or the husband or however they say they just cannot they cannot expel that mucus, and these are problems which exist for a long time because they can't cough, they cannot bring out their mucus, their secretions. This tends to be a symptom which the patients talk about even before asking them about it, but this should always be monitored. The test to evaluate the inspiratory musculature, which is we're most worried about because of respiratory failure, they're not the same tests which evaluate the expiratory musculature. So within the maximum pressures, the PIM evaluates the inspiratory musculature, but the PM does it with the expiratory musculature. And we do not breathe with the diaphragm. Expiration is done with the abdominal musculature. So the way to evaluate this would be a maximum expiratory pressure. And as far as I'm concerned, it's much more practical to have a COS, to see what the COS peak test would be more simple. This is a peak flow, and this is something, it can be homemade, shall we say. It can be done, an asthma peak flow. Asthma peak flow, you get it in pharmacies. All asthmatics have one. And you can use a mask because it's very difficult to cough into a tube, of course, because a lot of force is lost. But with a mask, we just ask the patient to cough, and this. It's not very precise, but to measure the cough, but it should be done with a calibrated pneumotachographer and a turbine. But I can say that if the patient's cough we can just see if this cough is efficient or not. And more than 240 liters per minute, And this is nothing more than just a cough to see how far the little peak flow device moves. And then we see the patient will be able to expel secretions when he does have them. Usual dose is around 400 liters per minute above the threshold. And with less than 240 liters per minute, this would be considered, even when the patient does not have any problems with secretions at that given moment, because precisely that moment there's no secretion, but maybe 1 week after the coming that there might be mucus and phlegm, then there should be some technique should be evaluated to check the dose mechanically or manually. However, this is a functional test as any other, and this should be done and each time the patient comes to our office. In fact, we and all of our patients, not only Pompe patients, but in neuromuscular diseases, when we see them and each time they come to see us, besides studying their vital capacity, blood gas exchange, we check the cough peak flow. And we saw, since the 1950s, the cough effectivity, to be able to take out this, expel the secretion depends on this airflow that is generated. This maximum flow that is generated during the cough is the cough peak flow. And it's very simple here. When the patient blows and does spirometry, we say cough, and in a moment we measure this. And as Anna says, this is evaluated, and after a given moment, even though the patient might say, no, I'm coughing just fine. Yes, but there is a cutoff point, a cutoff when the cough is effective or not. No, there's a very simple explanation here. We have all experienced this. When we have a cold, we all feel horrible, we're tired. It's because during these respiratory infections, there is muscle weakening, and even with the respiratory muscles. So I'm a Pompe patient who is weak, and that weakness, it gets worse because of the infection. And then 20-some days go by, and this drop, it's a sudden drop. It drops in 24, 48 hours of the strength of the respiratory muscles might mean that a cough might seem to be effective, it might become ineffective, and it might mean that if a patient has a cold, that he would be very unwell. So almost all of the times, one must use techniques, assisted cough, even when the patient might say, well, I cough okay, or we're seeing values where we know that the cough is or is not effective.
And that preserving our cough force is one of these habitual things that needs to happen, because we can't necessarily predict when we may become ill and weaken. I think another thing to bear in mind is that in a coughing effort, there are typically 3 phases, and the first phase is to take a deeper breath than normal. So while the forces generated, the expulsive forces, I won't do that in the microphone, while those are of course expiratory in nature, we take that larger breath in, we bear down, and then we expel the air. And so those other portions, the other inspiratory muscles, the airway closure muscles, those need to coordinate well in addition to the expiratory muscles. And that may be something where our patients who are not generating as effective an inspiratory effort, maybe the cough assist device also can provide assist not only with the expulsive effort, but to help generate improved volumes at the starting point of the expulsion. Any other comments on airway clearance cough? Okay, there are a couple of just hodgepodge things that I know came up in our emails in preparing here that I just wanted to throw out there. Sometimes we receive questions about other pulmonary therapists. So, for example, I I have trouble breathing sometimes, so why hasn't my doctor prescribed oxygen? Or would an inhaler help my breathing? Any thoughts that you might have to share on those matters?
Sí, sobre todo porque hay pacientes aquí.
And above all, because we have patients here with this situation. The difficulty to breathe is not cured with oxygen. In neuromuscular diseases, it is possible that sometimes oxygen is needed, but it tends to be transitory because of a respiratory infection, or the patient might have an important comorbidity such as a COPD or emphysema, and then besides having Pompe, but that was very strange, but that could be the case. Excess oxygen produces an excess of carbon dioxide retention. So if a patient with neuromuscular disease has weakness of the respiratory muscle, it is not a problem because of gas exchange. It's not the pulmonary tissue which is being affected, it's the respiratory muscles. So this is a mechanical problem. We need to put in air and pressure in order to inflate the lungs, but with the amount 21% oxygen, which is what we're all breathing right this minute. But when we give oxygen, of course, you put the pulse and the oxygen goes up, but you're not correcting the problem. You're just increasing the amount of oxygen you're giving to the patient. But you are not only are you not correcting the mechanical problem to move the respiratory muscle and to inflate the lungs, but what you're doing is you're just hiding the real problem. When a patient with Pompe disease without any infection or any other comorbidity lowers the amount of his or her oxygen, it's most likely because the amount of carbon dioxide is high and has been high for months. And the cause of this problem is mechanical, not because of gas exchange. A Pompe patient with respiratory involvement comes in, which puts the pulsometer in, because everyone has a pulsometer in casa ever since COVID, everyone has that. You put your pulsimeter and you've got 90%. It's a mistake when you to measure that, because the problem isn't the 89%. It's that you're going to have your carbon dioxide at 70, and when you're adding oxygen, not only are you not resolving this, you're just hiding this. And the oxygen excess, hyperoxia, leads to an increase in hydrogen dioxide increase. So it's going to worsen the situation. If there is a decrease of oxygen outside of a respiratory infection, you must consult, not to give me oxygen, but to evaluate my respiratory musculature. I agree with Anna. It's very important. I am going to focus this from another point of view, from the doctors who prescribe this. And this is a pity. It's because of not knowing enough about the disease. These are rare diseases. And when a respiratory patient comes to a primary healthcare doctor, and I give a bronchodilator, a bit of oxygen into home, and the patient ends up in a coma in the hospital. I've seen this. Even in the emergency at my hospital, a neuromuscular patient comes to the hospital, and he's treated as if he were an asthmatic patient. They have him stuck in a corner with oxygen. No, he's got low oxygen saturation. The patient, little by little, the carbon dioxide goes up, and then it's very difficult to recuperate this patient. So we're going to have to remember that not all respiratory patients, they're not all the same. They should not all be treated the same. An appendicitis isn't treated the same as a cancer of the colon, and these are problems of the abdomen. So here in the respiratory tract, the same thing occurs.
Muchas gracias.
Very insightful and important information, I think, for our participants. We have a little time left, and I think if there are any questions that, okay, yeah.
They have to wait for the microphone, otherwise we can't hear the questions.
Great.
Bueno, lo primero que tengo que decir es que yo
First, I'd like to say that I was lucky enough that with different patients, we went to Dr. Sancho, and he was in a Cervera hospital. And I was very lucky because I left that hospital with a volumetric ventilator. And she was saying, she was telling me what I had, but couldn't understand. But I use the BPAP and the ventilator. Are they different? Are they? Of course, the BPAP, it's to give air, but the ventilator is an electronic lung, so the lung will work. But I think there are doctors who don't know what this is all about. So I go to the hospital and I say, I want a BPAP. No, a ventilator. So I'm going to finish because doctor, but you doctors have left everything very clear. But some doctors just don't understand. In hospitals, and you go, I have to explain to a pneumologist, to a neurologist, or what have you, hey, there are other things that you can use. And they say, listen, the gasometry it's painful. Their arteria, well, never hurt me. I guess maybe some people it hurts, so that's what we do. And then I can do it every few months, and then so with this, a miracle would have to happen. This is why the only thing I've been thinking about is to tape your presentations and to show my doctor and say, hey, learn from these doctors. Learn from these doctors. In fact, BiPAP and the volumetric ventilator are both ventilators. What happens, and their function is the same, to put air in under pressure, but into the lungs. What happens is one. The BiPAP, we program pressure, and the ventilators send air until the pressure that we have programmed is reached. And so with the ventilator, air is sent until the amount of air we've determined, regardless of the amount of pressure they need. They're both equally effective. What happens is you have to know how to handle it. If you work with BiPAP, you have to learn how to work. If you know with volumetric, you need to know how to do that well. But a patient with Pompe can either have a BiPAP or a volumetric, as long as they are adjusted correctly. Yes, that is the case. They're not using a microphone. Hello. I'm behind the column. I'm hidden back here. I was going to ask a question, but first I'd like to make a comment. What Ignacio said about gasometry. Many patients, they say, oh, and I don't want that because it hurts. And they say, oh, what about anesthesia? But what hurts more is the anesthesia than gasometry. If gasometry is done correctly, then it's like it's nothing. My question is for Ana and to all of you, actually. In respiratory physio in Spain, and it's nothing here. It depends on the interest of the patient, him or herself. So I have exercise devices and apps, and I have an app. The problem is how can we choose exercises, the right exercises, and if the exercises are considered to be used for Pompe patients? I know that people use these for sports activities, and they say respiration because you want to just force your chest cage to take in the maximum vital capacity. How can we ourselves do this? How can we get information to be able to do exercises and so it not harm our diaphragm? Thank you. Yes, of course. You just imagine if we don't have physiotherapists, how can we even have studies about that? It's unimaginable. But we must individualize, personalize the type of respiratory physiotherapy to be applied. They're not the same physios. They're not the same for an athlete who wants to get greater lung capacity, respiratory capacity, if he is a deep-sea diver, for example. So what I believe, and I know that many studies should be carried out because we don't have enough for each and every pathology, but Pompe disease, well, the lung tissue usually is not involved. So this will not be pneumothorax, which is the greatest worry of respiratory physiotherapists, because, if smokers would have emphysema, but not normal patients. But this is a progressive disease, and it causes muscle atrophy. The main objective is not to necessarily gain muscle strength. It's just not to lose it, but to conserve it, to preserve it. So it's important to do, you should monitor this physiotherapy using a parameter, whichever one you wish, and to see that that muscle strength be maintained. In this sense, we can use spirometry, you can use in maximum inspiratory pressure, the PIM or the SNP, but the best thing would be to monitor this every 2 or 3 months just to verify the fact that you're not losing muscle strength. The problem is not to monitor, but my problem is that I sleep with a BiPAP, and it's a hospital device. And I can do the exercises I wish, I can put the pressure I wish, and I can put it in a pen drive. I can do what I want with this. Yeah, well, be careful there's no... Well, be careful it doesn't get blocked. Careful here. Sometimes I think it's important to know how these devices work, but the problem is that there are tools, but we really don't know how to use them correctly, and the professionals don't know either. Respiratory physio and myself, we have a reference center in Barcelona, and they do know. But rare diseases are not a priority in any reference center, in any great big hospital in primary health care, and even in third-level hospitals. Yes, you're completely right. Well, we need a lot of training, and in physiotherapy in general in Spain is in respiratory musculoskeletal. It's not so good in respiratory physio. It's practically non-existent. Many of the techniques for rehabilitation of the respiratory muscles with physiotherapy are designed depending upon the values that Anna mentioned, the maximum inspiratory pressures. And to work on inspiratory muscle, you need to regulate the function of parameters that have been measured previously, and unfortunately you cannot do it in your house with a tablet or anything. We do not have enough respiratory physiotherapists for them to design your own personalized program, because what is good for one patient isn't necessarily good for the next. In my case, in 8 years, my physio did just moving my muscles. I certainly don't think that's enough. The incentivator, the 3 little balls, yeah, that's not enough blowing. I do the same thing. I blow on those little balls. So the 3 balls, little balls, and you blow, you have to, yeah, but you always have the same resistance. So you can just prolong the inspiration time, but the inspiratory isn't the same as the pressure. So these 3 little balls, and the traditional use was to avoid atelectasis. And so for muscle training, this is it's not good enough. And the ARIFET application that was mentioned by the Public Health Care Services, Ifrit, what do you think? No. It's ARIFET. I have nothing to say about that. It's a pity. It's a pity. Anna was mentioning this because there are physiotherapists, and you need to get a very high grade to get into the universities to study physiotherapy, but very few people are even interested in respiratory physiotherapy. The rest just get a bag of what? Well, they say, blow here, put the hand on your abdomen and see how you breathe. This is completely useless. There's a whole world out there, and in Spain we're in prehistory. Unfortunately, we are in the prehistory along with this. And there's really not much we can do. If you, well, maybe if you have someone can help you get into the National Healthcare Service and you have an in there, who knows? Well, this has to do with pneumology. If with an intervention, and we're going to undergo general anesthesia or a test, the same thing happens. The anesthetist, I tell my anesthetist because I'm afraid if I have to have an operation, what should we be particularly careful with? For example, I had a colonoscopy not long ago, and I took my BiPAP, and I said, "Are you going to need? Will I need my BiPAP?" I went with my little device because I didn't know, but they don't know anything, and if they don't know anything, they'd really. Well, anyway, this happens everywhere, all around the world. This is a struggle we know ventilation pneumologists to domicile have constantly. People with respiratory problems, and you use your BiPAP at night if you're going to be sedated, this will also have to be used. It is some anesthesiologists prefer not to use it up front, but they are monitoring you. So while the operation is in course, they're monitoring you. But as soon as your saturator or your carbon dioxide goes up, they're going to have your BiPAP to be able to check. But the patient should always take his or her device along. So we recommend with any type of sedation, adapt the BiPAP, which is your own. The patient puts it on himself. I put it on by myself. I turn it on, and that's it. But it's facts. The fact that almost all anesthesiologists prefer to start their procedure, and if there are any complications, then we'll put the BiPAP on. But usually this goes along with a call to the pneumologist because they say, "How do you turn this on?" Well, the patient knows how. Well, he's sedated, so well, he should have turned it on before. But always, you've got to take it with you for any hospital admission or an urgency. You don't know if you're going to be in the hospitalized or for any scheduled operation. Before your scheduled operation, consult with your usual pneumologist so that he will verify that the pressure of the respiratory are good, that there's no important leak, that everything is just fine and dandy. Hello, good afternoon. First and foremost, I'd like to thank you ever so much for your presentation and thank you to the association because I've been coming for some years now and I have learned so much today and other years. I think that we focus so much on respiratory involvement, and I think that we haven't in the past looked at this much, but now more so. It's very interesting. And Barbara, I've known you for some time now, and my daughter is asymptomatic, but it's true that many doubts and misgivings come up after listening to you all today. Maybe you've already said it, but I'd like to be clear about this. The first thing is we mainly go to the neurologist and in La Paz Hospital, and sometimes he does spirometry and a little bit and not much more. And from the motor point and functional point of view, everything is fine, but at nighttime he coughs and wakes up coughing. And so, and his mother and I ask ourselves if this might be a first symptom that we should keep watch over, and if this might be that the diaphragm, which is one of the involved muscles, it might be the one that might firstly show these symptoms. That's very rare. The respiratory debut in Pompe disease is rare. Almost all the patients with this respiratory problem, it's very odd and rare for it to begin with the diaphragm, although cases have been described.
What's the age of your daughter? Well, there are not so much mucus at school, so that to be coughing at night. In the next consultation with the doctor, the children per protocol should have polysomnography done to detect respiratory involvement. And the study should be done not at home, but in the hospital with EEG monitoring as well. One of the doubts we had, because in the last sessions, a couple of spirometries, when she had some mucus, they were doubts if she could be asthmatic or not. She had also a certain allergy, as everyone, to graminaceous and to grass, and they had doubts about that interference. Could one confound the onset of symptoms with being asthmatic? No, never. No way. Well, if a neurologist, supposedly serious that in La Paz in Madrid, says that they should normally are not wrong. But you mentioned that she wakes up at night, etc. Well, this doesn't happen, but it was in a given period of time. Maybe this coincided with allergy issues due to the season of the year. It was last year. The symptoms of asthma have nothing to do with the symptoms of hyperventilation nor sleep disorders either. You can't confound them. Asthma has nothing to do with waking up at night. If she wakes up at night coughing, and yes, this could be, but this is not repeated. It's very occasional. They don't persist in time with wheezing or from asthma. With the suspicion of the Pompe diagnosis, you can't play with that. You have to make the sleep study. Another thing that is not too clear to me either yet, the level of functionality of the diaphragm. Is it evolutive? We have never had a diaphragmatic MRI, but can they see if the diaphragm is involved, or is that an evolution? From the first ultrasound, you can see if there is a diaphragmatic evolution in a very clear-cut manner, by the way. Thank you. I wanted to ask the test that you are talking about, how often is it done? How my child does also cough. He wakes up coughing. He drinks water, and that helps him. He is also asymptomatic. And I wanted to know if the test that you have mentioned, how often is the sleep test, the polysomnography. Normally, if the polysomnography is strictly normal, we can do that every 1 or 2 years. And apart from that, if we have any suspicion whether there is a symptom that may suggest that she can have respiratory problems, then I do that as well. You are not playing around with it. You do it whenever you have the suspicion. It can be accompanied by headache, and headache, in fact, makes you do the test even earlier, because the child, if he has headache, until now we were thinking that it was a contraindication normally of the treatment or something of that sort, or of his own, that he was nervous. So the test has to be done. There are tests that you think about doing them or not. A lumbar puncture, but an invasive test, there are too much risk benefits, sedate the child, etc. But a sleep test, you have to do that. You do it and that's it. Because it's very easy to rule out any problem, and it gives you a lot of information, prognostic, from the prognosis, follow-up, etc. And can it have something to do with the movement, the eye movement as well? The eye movement are part of the sleep phases. There is a phase of slow eye movement and one of rapid eye movement, and this can be normal. The rapid eye movements, this is physiological, this is normal. But it's not normal that they don't sleep well and that he has headache in the morning. You have to see that. It can also be at midday as well when he complains about headache. You have to look at it, yes. Thank you.
I do think we need to stop here. Thank you so much. We had a wonderful conversation with you, and we'll be happy to continue on break, but we do need to move on. Thank you.
¿Me oís bien, no? Sí. Uno de los objetivos de contar con un registro de pacientes.
One of the we have of doing records of patients with Pompe disease is to have data for the neuromuscular disease and rare diseases. A registry in which, from the Association of Pompe patients and with collaboration of the medical experts and of course of the people who are involved in the family as well, we are working on. And we have now data that we will know today. The survey that we gave to all the members a few months ago is helping us to keep on knowing and going to more in depth in the disease. Data that you're going to know from Dr. Genaro Martín from the Hospital La Paz in Madrid, whom we invited us to be here with us. Let's hope I can find it.
Hola, bueno.
Hello. I hope that I can give some interesting data. It's quite simple with the talk, my talk, introduction to the disease that is not going to be new for anyone. We are going to talk about the registry, what we have seen, and four things that can be interesting as well. And then finally, we'll talk about the survey that I had to analyze, and I can give some conclusions with it. I would like to, well, this is better, more than what I can tell you now. We talk about the Pompe disease. It's given to a deficit of acid alpha-glucosidase mutation in the gene GAA, and it is known as glucogenosis type 2. The glucogen is accumulated in the abnormal form in the cells, producing activation of the lysosomes, and this entails an accumulation and a progressive deterioration of many types of cells, but mainly of the muscle cells. Classically so, there are two forms, the classical children's child Pompe under the age of 12 months with hepatomegaly and as a definitive form, and then we have the late adult form, although it's not so adult and not so late either. Very often the child that at 1 year has this onset we consider that as a late onset already. That is the non-classical infantile form. It has a more muscular profile. And we have to understand that until a while ago, there were no data that talked about the epidemiology of the disease at the level of in our country. And that's why we tried to form this registry, the Spanish registry of Pompe disease. And it's a registry that is hospital-centered, in which the actors are the physicians in the units of the degenerative diseases, muscle diseases, in all the whole geography in Spain. They collaborate with us, and they receive the data of the patients and analyze them and accumulating them in order to have viable data from the patients. The coordinator of the registry person was created. In this case, it's myself. We communicate with the different places, introduce the data, and also spread the data, manage the data, and publish the data as well. We have two ways of accessing the physicians. One is telematic, and the other is personal. I have a picture with people. Some of you are here with me as well, and we see different in different places. But now we're not going to talk about that. We are in many hospitals, nearly 30 have collaborated throughout the geography. I'm not going to talk about them anymore, but I would like to mention.
Because I'd like to speak about some data that we have. We have 130 patients who've been recruited to the moment, and the average age appears up here. And you can see the results here. Look, that's because this is a bit asymmetric. And then And then there are two types of disease here. In Spain, we can see there are different registries, and above all, we see the adult type, And in red, you see children. This is young children, and it's interesting to notice in our particular case, and look at here, the late onset patients. Well, we have the most common mutation, and we have information from 100 symptomatic patients. And this is difficult for me to tell you about this, but I think that we can speak a bit more about this. But respiratory failure is quite important, and we've already have 40 patients in our cohort who receive some type of ventilation, support ventilation, that is. I'd like to tell you about two interesting things. These are interesting symptoms in the adult patients. I want to underline respiratory failure. And as our colleagues said beforehand, we have symptoms, and this is very important. We know there's a weakness in different muscles. And with children, I'd like to say one interesting thing. In our registry, the fact is that one of the first symptoms that we see is the cardiomyopathy. This is always an important symptom. We see it in children, but it's what appears most early on. And then we always see this in our therapies. A few more words concerning the epidemiology. And here, we don't have the 130 patients up here, but when we speak about, we have Andalusia, Catalonia, and it seems that Catalonia shows, we can see this up here, but then when we see in Andalusia, it seems that most of the parents were born in Andalusia. Well, the children were born in Andalusia, and then they immigrated. And so this contrasts with the fact that others were born in other autonomous communities. But it's curious that most of them come from the south. There's more of mutations that in the south, and predominantly in Cordoba. And this is a patient survey, and this is a survey that we did in July. And I think some patients, most of them filled this out, but we have data from 50 patients who answered these questions, average age, about 40 years old. And curiously, the parity was quite well between genders 25 to 25. And most of these people belonged to an association. Thanks to the registry, we were able to learn more. And quite a few had other pathologies as well. I'd say about a quarter of these people had other pathologies, and 88% received treatment, and 8% were confined to their own homes. And treatment, the time that the treatment had gone on was about. We saw this in about 9%, 9 of these patients. And in neurology, and this is something that we look at. And one thing we look at is the loss of grip strength, for example. And I'd like to mention the same as in other information that came from our registry. The people who answer our surveys came from Andalusia because it seems that there are more patients who were born in Andalusia. And other symptoms, it's true that there's nothing new under the sun, and it seems that when we interviewed these patients, almost all had weakness in their lower limbs, mostly the lower limbs, more so than the upper limbs. And the neurologist sometimes don't usually look at the pain. More than half the patients felt and had chronic pain or pain of some kind. And in the interview, they would say, well, sometimes they felt quite a lot of pain. But they always spoke about myalgias and type of pain in their muscles. What struck me as a neurologist, I was wanting to ask my patients about pain. So something else I think is interesting is that 1/3 of the patients who were interviewed were not in agreement with the moment or the time that they were treated and their diagnosis. So they say when they think that they were diagnosed right up front, but sometimes the patients felt these symptoms before they were even diagnosed. Well, it's a fact that many of these patients have important disabilities, and some have an absolute disability. Something else that is interesting and which struck me was the survey at 6.1 years. Well, it's curious that there was another registry that lasted 11 years. Maybe each registry was handled in a different manner. Maybe there is some type of problem, and some people have an earlier or a later diagnosis, and some patients say that they have been diagnosed, but they still don't have symptoms according to the registry. Well, the fact is that there is a change, and that refers to 5 years. Maybe, well, obviously some were diagnosed earlier than others, according to the registry. Well, almost 40% of the patients were diagnosed 10 years before. Maybe it was even more so, and maybe things are changing now as more people are informed. But something that struck me, and it's not a scientific truth, but when we look at the dispersion in these diagnoses, there was a certain tendency because the later the diagnosis, the greater is the disability that the patient will present in the end. There's something else that struck me when we speak about the symptoms and what the patient tells you that what he or she needs of some type of support. 1/4 of the patients need a cane, others need a walker, more than half need a wheelchair for their daily lives. But there's a very small percentage, and it's this one, that just need these special splints for so they won't have foot drop. This struck me quite a bit because some people have feet like this, and here, and I asked this person to lift his feet, and And this like you call it equine feet. And these are patients who've been treated from a very early age, and they have a distal weakness, more so than a proximal problem. This is just an anecdote, but this is something that struck me definitely because it's difficult to notice in a registry of a lot of patients. But if you have a sample of just 50 patients, when you ask these questions, you can get interesting little bits of information. I think it's quite striking. And of the 50 who responded, we asked what their follow-up was like. 42 if they had stress tests, and 41 respiratory tests, and 13 muscle tests. And I wanted to show you this graph. And in red and in blue, well, blue means stress test, and green, MRI. This is different. Some have a stress test, some force or strength and respiratory tests, and some did not even respond, and some, the three. I don't know why, but this does show that the follow-up is different from center to center. Maybe there's something deeper behind all of this, but I just wanted to show you all of this because this is an interesting finding. Lastly, or next to the last actually, I wanted to show you something and support. And 50% received some type of support and physiotherapy, but there's an error on this slide, but just 2 had physiotherapy that they did not pay for. That was funded by the association, but the rest, they had no type of aid. Lastly, quality of life. We're looking at this now in our studies and in science, and this is something that we want to ask, that we ask the patient about his or her quality of life. And so, well, general health, ability to perform physical activities, and mental health. There are patients who say so-so or bad, and this is in green. And purple. Purple shows, well, this is a chronic pathology. And so, to conclude, I'd like to mention that Pompe disease it's infrequent, but it's with it, but it has a real dependency burden. And the National Registry comes from true information about the number of follow-up and the number of patients with the disease. And we can look at new aspects of this disease, and we can think about things that haven't been reported previously. I think that this survey gives us important information, because up to the moment these things were not even considered. The patient was in the center, and lastly, I would like to say that the care is not always fair. It's not always equal, and there should be a consensus here. There is one, but we should make this more obvious regarding the follow-up of these patients. And without further ado, I will. This is the registry that I wanted to tell you about. Thank you very much.
Te entregamos un obsequio.
Well, I would like to give you a gift on behalf of the association. I wanted to ask a question first. This is more concerning the data you presented. It's something that is important, in my opinion, to point out. The diagnosis in the sample of 6 years is that the association, Pompe Association, is a very recent association from 2017, and the sampling of persons is not the real sample of all the Pompe's patients. There are many people who have not, whom we haven't reached, that are those that we have started the treatment initially now. 11 is even too little, but it was only that assessment of the data that you have given us. It is true that when we calculated that, it's certain that it's true that when we have to match, so to speak, the patients who already have a prior diagnosis, prior to the symptomatology, it's more difficult to quantify how much is that, because in theory we are diagnosing before the clinical picture setting. Sometimes it's hard to say how much is really the diagnosis. We have to say, how we think about it as something negative. It's not so easy to do that. Microphone, please. Contribution. I'm going. Javier Fernández Salido, the father of Lucas, who was the patient who received it for the first time. The therapy in Spain. He was a scholar of everything that had to do with Pompe's disease. The establishments, all from Carolina and all this area that we. I don't know if it was Carlos II or the King Charles II, and many people from Holland did also go there. If you study the amount of patients that exist, I don't know now what's the term, says the speaker, per patient, per person is in Holland very high. It's very well studied, and they have been studying for many years. But he maintained their thesis, and when the 26 have come up, well, we Andalusians, we gave something to Spain. And then we go to Barcelona, we have to distribute everything. And when I tell that, and in some congress and meeting, they say, doesn't have to do with Maghreb in Africa. Well, I don't think so, I don't know. Not all patients who come from, it seems there are no Jews there. Well,
¿Hay estudios o se recoge alguna?
There are studies. Do they collect that this information of more cases is due to consanguinity relatives, close relatives who have married each other, and the parents are related? Consanguinity. I have different. The haplotypes are different from the variables one, but most of the people with Pompe disease are two different variables. There are necessary to have two variables to diffuse the disease. There are some that have the same variable both, but it is true that most of them are different. So when we study the variable of father and the mother, most of the times they are different. So casually, we all are carriers of some disease, but when we have children, normally, due to mere statistics, they don't inherit the disease as such. But sometimes this type of problems happen, and they are carrier of bad variable. They produce the disease in the child. In our study, it's very infrequent, at least this intermarriage, this consanguinity, if we look at the variable alone.
A continuación.
And now, now we are going to approach one of the issues that has the greatest incidence and interest for the patients who have Pompe disease. The clinical updates, the update of the clinical management, late Pompe and childhood Pompe. We will talk about that with a strong conviction that the clinical and therapeutic decisions for the patients with Pompe should be taken in the setting of multidisciplinary boards that include all the specialties involved in the management of this disease. An update of the clinical management that will always have as the basis the research in order to approach that topic. We welcome Dr. Nuria Muelas from the University Hospital, Polytechnic from Valencia.
Moderadora de la mesa redonda.
The moderator and the participation of Dr. Cristina Dominguez from the 12th of October Teaching Hospital in Madrid. And Dr. Javier de las Heras from the Cruces de Vizcaya University Hospital. Good afternoon, one and all. It's a pleasure to be here with patients, relatives, and other professionals involved in the care of patients who have Pompe disease. I am Nuria Muelas from the La Fe University Hospital. I am a local here, and it's a pleasure to have on my left-hand side other colleagues from Spain who are going to introduce themselves and later will talk. Good afternoon. Thank you to the organizers for having invited me one more year to participate in this panel session. I'm Cristina Dominguez, and I work in the 12th of Octubre Hospital in Madrid with Dr. Ana Hernández, who is next to me, and I'm delighted to be here. Good afternoon, one and all. Thank you so much for inviting me to be here. It's a real pleasure. I see people I know out there. I'm Javier de las Heras. I'm a pediatrician, and I work in the Cruces Hospital in Bilbao. I work with hereditary metabolic diseases, and lately I am getting experience with Pompe disease. And the fact is, it's a pleasure to be here with all of you this afternoon. Very well, we have organized this panel session, and we are going to show a few slides. Each one of us will focus on certain aspects. I'm going to speak about general aspects tied into general research, that is, because the later sessions will speak in detail about gene therapy, new enzyme therapies, and the like. And Cristina Dominguez, who is a neurologist, basically an adult patient, she is going to explain what research is going on in the adult Pompe patient. And Javier de las Heras will focus more on the infantile and pediatric aspects. We're going to do a bit of gymnastics here, going from one end to the other. Let me look for my presentation.
Un placer estar aquí y espero que
It's a pleasure to be here, and I hope that there are more patients are seeing us at home virtually, and I hope that we can contribute to a better understanding of aspects which might seem to be a bit basic, but at the moment everyone wants to participate in clinical trials, and so we need to know what we're coping with when we're speaking about research and in clinical trials. The first thing we need to bear in mind is what is a clinical trial. It's a research study in human beings, which looks at the efficacy of drugs. And clinical trials are developed by following experimental protocols, and they're highly defined, and to see which patients will be recruited, which will not be included, and what will be performed in these patients. For a clinical trial, many years previously, there's a preclinical phase, above all with these medications. As I say, preclinical phase. This usually starts with research animals, firstly with cells from the patients who do have the disease, and they donate their cells for research. These preclinical phases will last, well, quite a few years, an average 3 or 4 years. And this is important to define action mechanism, for example, of the medication, of the drug, what will curb or to cure, that would be the ideal thing, the disease, and what mechanisms are there for toxicity or side effects, undesirable side effects, and what could occur with our patients. Depending upon this, well, one will decide if these molecules will be viable or not. On the right-hand side, you can see that there are thousands and thousands of compounds that are under development. This is a funnel. Look at how it's getting smaller and smaller. In the preclinical phases, we see what happens in the end. And the clinical trial, you see that the proportion is even smaller yet. So with the commercialization, then we see what happens. So in the clinical trial phase, once we've had the preclinical phase, the first thing is we do have a research phase, and we have phase 1. Well, they're healthy individuals who voluntarily say that they will test these therapies, and we will see if there's a side effect or action mechanisms and the behavior and the distribution of those medications. Where we do labs, we study the pharmacokinetics of the drugs. And if phase 1 is suitable, it's when the drug will pass to phase 2 in the research here. The drug will be tested on patients who do have the disease. Phase 2 studies are studies which recruit very few patients, in fact. These are very reduced in size, these studies are, and we will see dose stratification to see the most adequate, most suitable dose to apply this to the disease. These are complex. They are done with very few patients and also in not too many centers. So we look at the dose aspect and side effects and tolerability, and we see if there's efficacy for the patients. Then in phase 3, once we've seen that phase 2, the drug is safe and it has a positive effect on the disease, this is when we shall begin phase 3 of the clinical trial, which will recruit a more important number of patients. Depending upon the disease, it will be numerous or not. And this concentrates patients from different countries all around the world. And this represents different races and ethnic groups to see if the drug is efficient in different individuals. And here we're going to test one single dose. And this, we've looked at this in phase 2 already, but here we're going to, above all, see more solid data considering efficacy. We're always going to be looking at the tolerability and also side effects. And in the end, a very small number of these drugs will go on to phase 4. This is a phase until the drug is marketed in a formal fashion and could be used to treat the disease. With all of this, we often want to know what is there for our disease and how we can find trials, research, activities to be part of this. Here on this slide, I put down the 3 different important resources to see what is being done in clinical resources. We have the Spanish registry of clinical trials. Then we have one comes from the European Drug Agency and one for the United States, which is the Clinical Trials Gov. And here you write in the number of the disease, the types of trials that are being done for this particular disease. And here we must bear in mind that not only do we research in drugs or potential therapies, but also there are observational studies and studies of natural history, which are also very important for these diseases. And sometimes we don't know too much, but we're always learning continuously. On the right-hand side, I've put down a study of the natural history of infantile onset Pompe disease, and the therapies conclude that this is a potentially lethal disease. And so we are learning more things from these studies of the natural history of the disease, and also the importance about the registries, patient registries. And here we'll know how many patients we have in our country, their characteristics, and we can even locate patients in order to be able to apply these types of interventions or trials. And so here the clinical trials are complex. I'm a neurologist, a clinical neurologist, but I also do research and I participate in clinical trials. I have been for quite a few years now. We began in 2008, 2009. This is when we began doing research in neuromuscular studies, and we participated in the first clinical trial with a drug for Duchenne's disease. And so I've seen the development of these trials and how more and more each day things are evolving in these clinical trials, and there are more complexities. The trial must focus on the patient, and the associations play a fundamental role here, a very essential role. Here we have specialized centers aware of these diseases, and they are able to recruit these kinds of patients. Sometimes these are rare diseases or ultra-rare diseases with teams of professionals who come from many different areas. Not only do we have doctors and nurses, but also we're going to have physiotherapists, lab technicians, people from pharmacies, and we have to have research institutes. And economically speaking, this is a lot of money involved here, and so there needs to be a participation not only of foreign companies or private companies, but also there are other studies that get funding. They have their own funding or governmental funding, or the associations also help fund these studies. So here we are seeing the complexity behind a trial. We have the evaluations and the functional tests, which are done very selectively to be able to see these changes in the disease. Each neuromuscular disease is going to have handicaps and more specific types of tests, and also drug delivery, very complex, because we're talking about gene therapy and Duchenne and Pompe as well, and how these drugs are delivered or administered. Well, this is highly complex. We have to have very sterile conditions, very specific conditions, and later we need to obtain and process, send samples, not only blood, but we do get a muscle biopsy and send that in to see if that drug, if that intervention has a positive effect on the muscle. This is our target organ. And then we do use MRI. This is a very easy test, and it gives a lot of information in neuromuscular diseases. With all of this, I would just like to conclude by saying that it's important to see how important research is and these clinical trials are. Actually, not only using drugs and looking at other aspects of these diseases, all of these are so necessary to move forward in the treatment of our patients and to learn more. It's very important to cooperate and participate with patients, with associations, and with family members. We need to have specialist centers who know how to handle these neuromuscular diseases and clinical trials. And because, as I've said, we have people from different professional backgrounds to back up this research project, even though the research, and we're all so passionate about this, but let us not forget how important it is to use the standards of care of these disease or other neuromuscular disease. And this must all be done very suitably, adequately, and in a multidisciplinary fashion. Economically speaking, the investment required for all of this, well, these funds, if only they could flow more generously from the non-private part, from public entities or associations and the industry. And with this, I conclude. And here we see our research group from LaPe University Hospital with all our colleagues. Nothing more, and thank you so much. I'll now give the floor to my colleagues.
Muchas gracias.
Thank you, Nuria. As we've said, I see exclusively adult patients. And the idea in this brief presentation was to review some of the news, the novelties in the last year as to basic research and clinical research is concerned. I have reviewed the papers that have been published this year in 2023, and I have selected 5 of them that I know the conclusions of which can be practical for your daily life. I'm going to summarize them rapidly. I'm going to focus on the conclusion of each one of these papers. The first that I chose talks about physical activity, because you know that there have been many studies that have been made, always with few patients, always very short studies. So it's not yet too well proven, but there is more and more evidence that adds that the physical activity on a regular basis in all patients with Pompe disease, adapted each one to their possibilities, improved their physical condition. In that paper, the Dutch group makes a study in a series of patients that they have been followed for more than 10 years. And what they do is analyze if those patients who achieve physical activity on a regular basis, when 10 years have elapsed, and they are under better conditions than those who were similar to start with those patients, but they led a different life, a more sedentary life, still life. But we regular physical activity is considered, and healthy activity are the recommendations given by the WHO. that are recently updated, but I followed those in 2010. At least 150 minutes of aerobic moderate exercise per week. Moderate exercise is to walk fast or in bicycle. Or on the other hand, 75 minutes per week of a very vigorous physical exercise. And this, for instance, is running. They say that apart from this physical activity, we have to add twice a week of strength training as well. This is what is recommended in order to have a healthy physical activity. What they review in this group, after 10 years, those who really have had that physical activity in a regular manner, compared with those who had a sedentary life, were clearly better in all the items analyzed, both in physical endurance and strength and the functional capacity. That means that the conclusion, once again, after this new study, is that, in fact, we have to try to promote physical activity, adapt it for each one to what they can do, but in patients with Pompe disease, that can be generalized to all the neuromuscular disease. It's essential to try to maintain as active a possible life as possible, because this has a direct translation into the muscle to be preserved as best as possible. In this other paper, from the Dutch group as well, what they want to analyze is the treatment of the home treatment, the safety of the home treatment. We know that when it was authorized for the first time, the Myozyme, it was done with the alert that it should be given in a hospital due to the risk of allergic reactions. In the Dutch group, they started very soon to make this treatment at home. And in this study, what they do is analyzing after 18,380 infusions throughout those years, the safety results. They established a protocol in which the patient, first of all, the first year of treatment, he does it in the hospital to be certain that he has no adverse reactions, and then a series of nurses that are trained, that know how to recognize if there is an adverse reaction and treat it as well, and that have a medical support team in the hospital that is on duty. With that protocol, they'd have done from 2008, I think, home treatments, home-based treatments. In this analysis that you can see, what were the reactions after 18,300 infusions, 121 adult patients, they see that the existence of reactions to the drug is very low. In the hospital, it only happens in 3% of the infusions, and in the home-based, in less than 1%, is there any type of reaction. And that the reaction that happens, most of it are mild reactions. When in the hospital, 80% are mild, and at home, 92% are mild reactions. A little fever, discomfort, and that type of reaction, stopping the infusion of the drug and then restarting it at a slower pace, they go over. They disappear. But they only observed 4 severe reactions in the hospital out of 20,000 infusions, and 1 at home that required care in the hospital. Those severe reactions that are allergic reactions are solved with the intravenous treatment of corticoids and antihistaminic drugs. The conclusion with this study is that the home-based treatment, in this case with Myozyme, but also with the new enzymes as well, is safe, always following a very strict protocol and starting the treatments first in the hospital. This third paper is a systematic review that wants to tell that they analyze the results of many different publications, and they focus on knowing if the antibodies generated against the drug have an influence on the effect of the treatment itself. We know that the infantile forms, especially the most severe ones, in which they don't have their own protein, there are immune reactions that are very intense that require specific treatment and that do have an influence on the benefit given by the treatment. But in the population of patients with a late onset, where we know that all of them will develop antibodies to the treatment, it's controversial still yet if those antibodies developed really prevent the drug to work properly. And they analyzed 17 different publications, analyzing a total of 443 cases. And they conclude that although the antibodies are produced in all patients, the titer of antibodies, the amount of antibodies generated in the majority of cases is low, or is low enough in order not for them to generate any type of problem. When very high antibody generation takes place. Nobody knows what's the limit to talk about very, very high antibodies. In some papers, they talk about 1 out of 12,000 or 1 out of 50,000. We know when there are many, many antibodies, but those figures are very infrequent. They happen in an exceptional manner. We know that even in those patients with antibodies that are so high, the immense majority of them are not going to have any effect on the benefit caused by the treatment, because although they are somehow neutralizing the effect when it's analyzed in vitro, what we have seen in those cases that at patient reality there is no change in the clinical benefit he obtained with the drug. So even the few cases that had very, very high antibodies, it doesn't seem this has an influence on the benefit of the medication. We have seen also as well that those patients who develop antibodies or more antibodies generally are the same that have some adverse reactions when the medication is introduced. Maybe these are patients who need a pre-medication when the drug is given. But very important, they are not interfering with the benefit of the medication. This paper of basic research seemed very relevant to me, especially in view of the new enzymes. Jorge will talk about the new treatments, and one of the new enzymes that will be tested is a combined treatment using the enzyme acid alpha-glucosidase in combination with an oral therapy that is an enzyme stabilizer. In this paper that is funded by Sanofi, what they try to show is that this stabilizer that is taken orally could also improve the activity of these two other enzymes on the market, Myozyme and the new that will start, the Biazyme, that is a new enzyme from Sanofi. The enzyme from Sanofi doesn't have a stabilizer orally. The one that has a stabilizer is the other treatment. What they want to verify is that if that oral stabilizer is also able to improve the activity of those other enzymes. It seemed interesting to me because we can think if such a drug exists that I take orally and that makes the enzyme work better, why don't take it, although I'm using Myozyme or the new one? And what they show is that they analyze both in vitro and in animal models, in mouse model, and they show that nor in Myozyme nor aval-glucosidase, that is the new one, adding miglustat, that is the stabilizer, oral stabilizer, makes the enzyme work better. The enzyme is working equally well with the stabilizers than without it. So it wouldn't be necessary to add any oral drug to those two enzymes because this doesn't contribute with anything. But what we show in this paper is that comparing the new drug with aval-glucosidase with Myozyme is aval-glucosidase is more potent when degrading the glycogen from the tissues. It had been proven already, and this is pointed out in this paper. The oral stabilizers would be indicated only for that other enzyme, aval-glucosidase, that is the one that requires the stabilizer to act. And this is the last paper. Just calling on your attention, you all have heard about ChatGPT. It's a chatbot with which you can chat. You have to know that in this type of chats, the content that it's returning to you when you are maintaining a conversation doesn't need to be truthful. It can be invented. You can ask about the disease and it can return you a content that in reality is not real. This is important for you to know because you can think about, well, I have here a chat with which I can chat that is connected to the internet. I'm going to ask about the problems of my disease, the treatments. You can receive in return invented information. I found this paper where many scientists using this tool in order to write the scientific papers more rapidly because it returns rapidly a text. And in reality, we have to know that it can give back to you a text that is false. So in this paper, they were asking about the Pompe's late onset Pompe disease. And they asked, describe the late onset Pompe disease and the liver involvement. And what the ChatGPT answered said that Pompe disease of late onset, there was a very important liver problem with a hepatomegaly that could lead to severe and progressive problems and hemorrhagic secondary disorders. So it has invented from nowhere a complication in this disease that in reality doesn't exist. You should know that in order not to use this type of tools as the physician that can use it for it's more accessible for him. All the papers that I had reviewed. Thank you very much.
Pues ahora Javier nos pondrá.
And now Javier is going to update us on the infantile onset Pompe disease.
Ya lo he visto, sí, eso lo he mirado. Pero lo de
Bueno, no sé si se me oye con este micro. ¿Sí? Vale, bueno, pues yo...
I'm a pediatrician, and I'm going to speak about Pompe disease, actually infantile onset, obviously, and I'm going to focus on the classic kind of this IOPD, the early onset. And I think that this is not represented so much because it's more rare and much more infrequent. Let us begin with a bit of theory. I think you already know about this, but Pompe disease, this is lysosome deposit where the substance which is accumulated in the lysosomes, you know that they're in the cell and glycogen is accumulated. And this is type 2, glucogenesis type 2. There is an accumulation of lysosomes in the cells, in the tissue, and then it causes the symptoms of this disease. And where does this glycogen, where does it deposit itself? In the muscle cells and in the skeletal muscle. This is the infantile onset type, IOPD. There are two different types in the clinical type. We have the infantile onset, IOPD in English, and we have the late onset PD, LOPD, the initials in English, of course. And the IOPD is the most severe kind, where generally speaking there is a complete absence of that enzyme. Children have very, very, very few of that enzyme or are not at all. And so they have to be treated very early on. Late onset may be diagnosed, for example, depending on when the symptoms begin, or if they're diagnosed pre-symptomatically, or when they're in their childhood or in adulthood. And so I'm going to focus on the IOPD, the clinic and the symptoms in a very just a baby. They have a very severe hypertrophic cardiomyopathy. The heart walls are very thickened, and weeks later, if nothing is done and they're not diagnosed, well, the child will begin with hypotony, with motor muscle problems, and with everything that we already are familiar with. So for the diagnosis, in absence here, if it hasn't in the prenatal screening, then we would have to suspect something, and so the test, the HEAL test, is done to newborns, where they rule out a series of diseases that have characteristics that if you find them very early on and they are treated very early on, this will certainly change the prognosis very importantly. And then this type of IOPD, from my point of view, would be a clear candidate. But in absence of this, if the earlier the better to diagnose this. But if we suspect this, and we doctors have to even know about this to be able to suspect it, then after that we do the genetic testing, and with enzymes, then it's very easy. So in the infantile type, it's very, very, very important to have a very early diagnosis. The minute you suspect this, you must immediately diagnose this, because if we begin earlier, better earlier than later, then if it's earlier, then the child will certainly have a change in his or her prognostic. He'll end up or not in a wheelchair, can live a normal life without a tracheotomy and so forth. This will all depend upon the early diagnosis. And when we begin, the earlier we begin the treatment, the better. So we certainly have our enzyme therapy, our enzyme replacement therapy. And here, the harm to the skeletal muscle is irreversible. It's arms and it's the heart. The heart muscle responds very well to the treatment, but the skeletal muscle does not, and the harm is irreversible to the skeletal muscle. So one should begin before there is a motor involvement. So in the IOPD kind, the severe of the newborn baby, we must begin immediately because days and weeks can influence the prognosis. But the LOPD, the late onset kind, this should be treated when the first symptoms appear of the disease. But here it's very important that they be followed in a very specific place where they know what they're looking for, because you're going to have to look with a very, very, very carefully to be able to find this early on. You're going to need a magnifying glass for this. And clinical case. And so why am I showing you a clinical case if we're not doctors? But I'm just going to reach some conclusions and give you some ideas about this particular clinical case. This is a baby, 2 months old, who seemed just fine. It came to the 2 months revision of the baby. The baby had not gained any weight with regards to the checkup after 1 month, and besides, the breastfeeding is causing a problem. It wasn't hypotonic, and the baby could suck the milk. The problem was the fact that the mother needed to get take the breast out and then put it in a bottle, and the parents and the grandparents gave the baby. They put a little urine bag, and it seemed that there was a urine infection. So the baby was sent to the emergency ward, but just to see if the baby could breastfeed or not. But only that. And a normal little girl, normal weight when she was born, nothing, no hypotony, tone, attitude perfectly normal. But in the hospital, the pediatrician did a good examination, and in the pediatrician's exam, and then it seemed that there was a slight murmur, just a very slight murmur, 1/6. So since we were in the hospital, we went to the cardiologist, and he did an electrocardiogram. You will not understand what this is. I'm not a specialist here either, but this is a heart, and it should be like this, like 4 or 5 times broader here. Seems that the walls of this heart are very thickened, and so this is very characteristic of this disease. So when one sees this, one should suspect this disease immediately. If you can see here, in this particular case, the diagnosis was reached before the patient had hypotony and the early treatment was begun. Luck, just by chance. This was just by chance because the child was admitted to the hospital due to another reason. A little murmur was heard, and the test was done, and that child had not gone, and the baby would have begun at 6 months with hypotony. Then the history would have been completely different for sure. So there were labs. They could see CK was high, transaminases. Look at the result. Well, Pompe disease. So now I'm going to show you the research. We check things, and then in the end, we see what happens when we write articles about our research, and so then all these articles help us reach our decisions in our hospitals, and because we don't want to do things just, well, I think this is the way it should be, and I'll do it like that. But no, we have to do things based on objectivity and very rigorously and academically, and so we should always base ourselves on the latest evidence, and so this means we have to look for information very rigorously. We have to look for scientific information and research information. 2-month-old child with Pompe disease, what do we do? Well, we're going to have to look and see what science tells us to do. So the first thing science tells us to do is we're going to have to hurry. Going to have to begin this enzyme therapy. The sooner the better. If you begin at 3 months, it might be too late. But so the earlier the better for our enzyme replacement therapy. What do the guidelines tell us? we do need to have guidelines from experts. It should be evidence-based guidelines. And so I don't know. This was in 2020. There were no updated guidelines. The latest guidelines came from 2016, 2017. And what do the guidelines tell us? They tell us that we need to immune suppress in patients who are CRIM negative in order to avoid the appearance of antibodies against the drug. What does this mean? Well, antibodies, I don't know if you know what an antibody is. When something strange comes in the body defends itself and creates antibodies against it and attacks it. It's something new. It's a foreign body that came into your body, and the leukocytes make antibodies against it to attack it. So if a patient has such a severe form and has absolutely no enzyme at all, when you're going to put the enzyme therapy in, it might recognize this as something foreign, and so then it will react against it. So in this disease, and in fact this does happen, so it means that the therapy would no longer work, and these patients die, because even though you apply the therapy, it doesn't work and they die. This is a huge problem. So research is done in CRIM-negative patients. We think that these are patients that have not one enzyme whatsoever, and they tend to develop these antibodies, and so they die. And to the contrary, there are other patients who are CRIM positive, and perhaps they do have a few enzymes there, but in theory, and generally speaking, they don't tend to develop this immune response against the drug. And so, although on occasions they do die. And so how do we know if a patient is CRIM negative or CRIM positive? Well, we're going to have to see if use Western blot technique to see if there's an absence of the protein. As we said, we're going to have to begin to treat the patient as the sooner the better, and according to we have to see the mutations. So here we can predict to see if the patient is going to be either CRIM positive or CRIM negative, although it's not always useful because if there's a new mutation, what often happens, it might not be described already, but you won't know if it's associated either to CRIM positive or CRIM negative. So the guidelines say, and that we understand what they say, immune suppress in CRIM negative patients to avoid the appearance of anti-drug antibodies before we're facing a huge problem. So ever since 2015, 2016, up to 2020, a lot has gone on. So we have to keep on looking further. So literature, what does it say? It says immunomodulation is safe. It means that before you give the first infusion to the patient, you give strong drugs to the patient so that the immune system is weakened so it won't make antibodies against the drug. The guidelines say this immune modulation is safe. I'm a pediatrician for metabolic disease. I don't know how to handle these drugs, but my colleagues in oncology, they say, that's okay. This will be just fine. It'll be tolerated just fine. The benefit might be quite good. So another article from 2018, it's an article from an Australian group, and says the patient was CRIM positive. He wasn't immunomodulated or immune suppressed. He developed antibodies and died. So if this happened to me again, I would have used immunomodulation, even though he was CRIM positive. So even though we decided with all of this knowledge and all of this information that we had we looked at our search in the literature, we immune suppress the patient regardless of the patient is either CRIM positive or CRIM negative. So this is our diagram. For our treatment, there was a professor from Duke University who knows a whole lot about Pompe disease, Dr. Krishnani, and she sent this to us very, very kindly. And so the enzyme is delivered every 2 weeks and immune suppressed with rituximab, methotrexate for the first month. As you can see, there are many, many infusions. This is a very hard first month in the hospital with lots of infusions to be able to do this well. Another misgiving, other doubt that arose, and with these treatments, what we did was to use a device so we wouldn't have to put an injection in the patient every time. It was a subcutaneous device. It doesn't hurt the patient, and it's there because it's always there. If you have to infuse chronically, you need to have this. So the colleagues from anesthesia said, well, of course, this hypertrophic cardiomyopathy, this very thickened heart, perhaps it might be a risk that something might happen to the baby in the operation to put this in, and it wouldn't. Maybe we should infuse this peripherally, and that might be better because the heart does improve quickly, and then you could put in your central venous catheter. So it seems logical, but let's again look to what science tells us, and maybe we can find the answer there. Let's look for the best answer. So there was a very good article, a bit old but quite good, 2007, where it refers to 139 patients with a well-documented disease, good clinical trials, which we heard about before. Everything is well documented, so everything was clearly documented. And 139 patients is a big number in Spain. I don't even know if we have 13 IOPDs now. 139, that's a lot. So only 9, that is to say 6%, had arrhythmia or cardiopulmonary failure after the induction anesthesia, and 2% patients died. However, what they did see is that all the ones who had died had a left ventricular mass index of, look at the number here, and it's a very thickened heart, but how thick? This can be checked out whether it's over 350 grams square meter. They had this in common. So what do we have to do here? Call the cardiologist and say, hey, this baby, what's the heart like? Quantify this for me. So there were 287 grams per square meter. This was less than the ones who had died. And so also we have to remember that the first month, there was a lot going on. They were infused every 2 weeks, but the first month, every other day, there were lots of infusions, very long infusions, and that tiny baby, 2 months old, tiny little arms, it's very difficult to get the veins. So we had a multidisciplinary meeting. We put everything on the table, and we decided to implant this before we began with the treatment, and everything went quite well. So what is the evolution of patients with this with IOPD? An absence of treatment, it's terrible. This is the survival curve. Here's 100% all alive, and then all dead. So you can see at 10 months, 12 months, 20 months, no one is left. In the absence of treatment, this is devastating. And for some time now, we do have ERT available to us, and this has changed everything. Before, everybody died. Now, not everybody dies. But be careful here, because this is far from being perfect. This is another survival curve with our enzyme replacement therapy. This is radically different. Before, everyone died, but here there is quite good survival. But the ideal thing would be that this survival here at 5 years, the ideal thing would be at 100%, and it's not the case. It goes down, and with quite a few added problems, because this is half of those who are still alive, and they still have mechanical ventilation. So yes, the treatment is very good. However, it's very far from being perfect. So these curves are when we've been discovering that there are other factors which can influence the improvement of these results. These are not the results of how things were done in 2020, for example. So there are new articles which are going to give us more information. This was presented in 2021, and so we are learning about things that we can use to improve this survival. Here's the survival curve, but it's not life and death. It's time when they did not require mechanical ventilation, invasive ventilation. So we CRIM negatives, immunosuppression, and to begin the treatment as soon as possible. Let me explain this graphic to you. It's a bit busy, but if the patient is a neonate, no enzymes, and if you don't immune suppress, it's almost as if you didn't give him anything. Over here, they're all going to end up with mechanical ventilation or dead. And here, if we immunosuppress, things are stratified, and so depending upon when you begin the first enzyme therapy treatment. If you begin this before 4 months of life, it seems that things go quite well. However, if you begin between 4 and 15 weeks, a bit worse, and then if you begin beyond 15 weeks of life, much, much worse. And notice that this is, if you begin before 15 weeks, this ERT, you will have to do the diagnosis, get the drug. They're very costly. You have to have a commission. You've got to do so many things before you can even begin the treatment. So in absence of a neonatal screening problem, then it's very, very difficult because you have to give so many things. And if you're lucky enough to do the diagnosis early on and you're at a center that knows what you have to do really very, very quickly, then lots of things have to converge so that you are able to do all of this quickly. And then besides, there's another factor which influences the prognosis. This is an article published the end of 2021, and this is a scientific magazine. The very good ones have a very important impact factor, and they only admit extraordinary articles, very, very well done articles, and this is one of the articles. This is a top journal. And so in our look at here, we see our enzyme therapy, and it wasn't perfect. We saw that the ERT was not perfect, and in real life, other things have been done, other doses have been tried to see that health of patients improve. So here, this is a survival chart, and in green, this is the standard dose, 20 milligrams per kilo every 2 weeks. In blue, the dose, intermediate dose, it's the double, 120, and the high dose is 40. So it's higher than what we saw in the beginning. So according to the last evidence, the dose at which you treat also plays an important role in how and what the prognosis will be in the long run of the patient. So this happened in 2020, and I didn't know too much about this before 2020, but then chance and luck meant that there's not one without two and not two without three. But anyway, the following year, another patient came, and we were very lucky because it was a very early diagnosis, and the first infusion of enzyme therapy was 18 days of life, and 1 year later, also very lucky because the cardiologist saw the patient, and he had his first, at 15 days of life, this enzyme replacement therapy was given. So these are our first two patients. The first one I said began at 2.5 months, and the next at 18 days of life. 18 days of life. This was published in a communication to try to see if anyone found him or herself in the same circumstances, know what to do. We followed the same treatment schedule. We used ERT, immunomodulation, and the scrim positive or negative. And we already have heard about hypertrophic cardiomyopathy. And so here we show what we saw beforehand. This is the left inventricular mass, and this is weeks after treatment. And you see that in green it's a patient, and in blue is another patient, but both began with a very thickened heart. But after 20 weeks, more or less, and using ERT, the heart was already normal. And so look here. Don't know if you remember, look at the wall is very thin here. And over here, this was in the beginning, how thick it is. See, look at that wall there. And this responded, so the response was spectacular here. And we look at the motor scale. They were very successful here. This is a percentile of the weight and the height, and we see a scale called Alberta Infant Motor Scale, and these two patients were considered as normal within this scale. One even began to walk alone at 10.5 months, which is really something, because any normal child, mine didn't started to walking when they were 15 months old. So this one really began walking quite early. And of course, neither of the two required ventilation or any help to eat, which would have happened almost for sure if they had not been diagnosed so early on when they began being a bit hypotonic, and if they had not had this early treatment and get their diagnosis and treatment. These are the labs, and this is also very important, immune suppression. Here we see the IgG antibodies, and these are these terrible antibodies that we're so scared of, because if they're expressed, well, in a maintained fashion, the drug might no longer work. So we measure this carefully, and it's been 0 with our different values. And so my in message, it's important in as much as we don't have a neonatal screening, it's important for doctors to be aware of the important aspects of this disease in case a patient like this appears before them, so they can identify and diagnose on time or in time. It's very important to have disease awareness, so that all doctors should be aware of this in case this baby like this comes in. Not say, oh, I'll see you next week. No, you've got to do the diagnosis immediately and remedy the situation right up front. So if there's a tiny child with a very thickened heart, you just should suspect this disease. And also the fact that the child not have hypotony, you think, Pompe hypotony, even though there might not be hypotony, and this doesn't rule out the disease. They should begin being treatment before hypotony occurs. And you must go fast, because the sooner the better, and we should begin before the first month of life. And as I said before, with a severe disease, with an efficient treatment, and where ideally one should begin the treatment as soon as possible. And the fact that this disease is considered, it should be in the neonatal screening. I think it'd be very interesting as you, as a patient association, perhaps you might have an important voice, and you could do something here with the politicians. I think the complaints from patients are better than what we doctors can say at the hospital, and nothing more. Thank you very, very much. Thank you for your kind attention.
Muchas gracias, Javier. Muchas gracias, Cristina, por las.
Thank you, Javier. Thank you, Cristina, for your presentations. I think it's the right time for questions now. If there are any questions with the microphone, please. I'm quite rapid asking questions. I'm even more rapid than you are, said somebody. Concerning the neonatal screening is something that the Patients Association, not only ours, but also from since long we have been working in groups. I would like to know, what do you advise? What do we have to do? Because except Murcia, that is the community that I think has 40 diseases, the other communities are, well, it depends on different things. And the other question, to leave the micro to another one, with concerning the issue of the dosage of the ASEM for the patients. It is quite clear that in the label, 20 milligrams in adults. In some other cases, it increases to 30 or 40. But in principle, the drug is implemented through cost-benefit. I would like to know if in the future, maybe there are new therapies, if it's possible that the adult patients, we also could have 20 or 30, or because maybe it's going to be better for us. I don't know how you see that.
Vale.
Well, I start with the one of the neonatal screening. It's a problem, I think. You know that in our country we have so many health care services as autonomous communities. So there is an inequality in the amount of pathologies that are screened depending on the autonomous communities where you live. So hence, practically more than half of the children in Spain do benefit from an extended screening, but there are other autonomous communities as mine, the Basque Country, where we have a screening that is extremely limited. So steps are being made at the level of central government and the ministry to try to unify everything. But it seems this is going to be quite slow. And it seems as well that the push from the patients' associations to the politicians maybe could help somehow. The advisors in the autonomies, health advisors in the different autonomies, it could be effective for them, or at least they hear it from several places, from several sides, and from the patients and from the other communities, and this can help. In Ceres, there is a working group in order to try to do something about it. But I don't know if this is, it's only we. I suppose that you are also doing something, that the medical community doesn't reach that point because you have the space that you have. But we also have from our scientific societies, we're also pushing. And so if everybody is pushing from all fronts at the political level, the push of the thrust from the patients, I know that they take into account, I know some associations, the organic problems, etc. Associations have been asking for meetings, asking it in a written manner, etc. And everything is, at the end of the day, we have to achieve that. I can't understand that they don't make the screening of many more diseases as well. So at the end of the day, it's not something that is going to save money. So many patients that you can change their life because you are on time when you find the disease. And from the economic point of view, I also think it's cost efficient. We don't have to bear in mind only the medical expenses for the treatment, or also the expenditure of the pilgrimage of the patients going from doctor to doctor, the intensive care unit, the cost of the therapies, the cost of parents who can't go to work because they take care of their children. All that has to be also weighed. I can't understand how this has not been extended, but I suppose this is going to happen. But until it happens, we all have to push so that it becomes a reality. And what you said about the dose, what I have said, we shouldn't be confounded. IOPD in the classical infantile form and in the lithoset form, my knowledge, the dose is 20 every 2 weeks, and with that it's fine, I think. If I give more, maybe it's going to be better. I don't think it's like that. It's not accurate to do it in that manner. Only say that as far as I know, in the adult form, this is not studied if the dual dose would be more efficient or not. This is one of the problems of this therapy, that the more you inject, not everything reaches the muscle. If you inject more will be coming to the muscle, but it hasn't been studied. This enzymatic therapy compared with the one of other metabolic diseases, the dose used is much higher already. So apart from doubling the dose, we have to see if it is safe to use such a high dose. As far as I know, this has not been studied yet.
Hola.
What happens if there is an allergic reaction, or that the patient, I don't know, she didn't finish the sentence. As our colleague has said, the allergic reactions are very infrequent, but this doesn't mean that they don't exist. So it's a problem, of course, a very big problem, because if a patient has an anaphylaxis, an allergy to a drug that is going to save his life, it's a big problem. So if you are allergic to something, to a drug, and you have had an anaphylactic shock that is severe, that is jeopardizing your health, it would be contraindicated to give it again infused in the vein. This would be terrible, not a good idea. But in patients with this disease, and especially in IOPD, the classical form, if you don't treat them, they're going to deteriorate and die. You are between two bad things, and there are good news because there are approaches that can be followed. The first approach would be to pre-medicate, try to give it slowly or more slowly to see if he tolerates it. If it's not so, there is another approach that normally gives good results. Desensitize, starting the infusion at a very diluted concentration. You give very, much diluted. So the body, the mast cells, the inflammatory cells that make this reaction are releasing their mediators. And then slightly higher concentrations, and then you put it at a normal concentration. The mast cells don't have anything to do any longer, and there is no reaction. But this is quite, people are afraid of it. It's a big problem, but we have ways of trying to solve that problem. The reactions are quite rare. The allergic reactions are not so frequent, but there are some cases. Yes, there are some cases. I have seen them. I have had one in adults as well. They can be managed, and there are resources in order to be able to do that as well. Medication with safety, but this has to be given in the hospital, of course. Good afternoon. I have a question for Dr. Cristina Dominguez. When you took the fifth papers in the fourth one, I don't know if I understood it well, they compared the use of the miglustat with its efficacy combined in the first generation RT and the second one, if I understood it well. And what the paper said is that it was the same. Basically, in the second generation, to implement miglustat together didn't benefit. To clarify the therapies, the first generation myozyme, second generation avalglucosidase and cipaglucosidase. In cipaglucosidase, it's the enzyme where we have to add miglustat so that it stabilizes the enzyme, it brings its efficacy. In the paper avalglucosidase, that is another second generation enzyme, they don't need the miglustat in order to be able to enhance its efficacy, because adding it doesn't change the final result. But at the end, you said that in the second generation dose, they compared the first with the second. They compared avalglucosidase, that myozyme, with avalglucosidase, the second generation one. In that paper, they didn't study CIPA, alglucosidase and avalglucosidase. The second generation is the one that shows that when the glycogen of the tissue is going to be degraded, it's 5 times more potent than the first one. The second generation is much better than the first one, at least in vitro and in animal models as well. And what you have seen until now, haven't you started yet? Jordi will tell about that within a while today. Thank you very much. Hello. In my case, for instance, we have the stabilizer miglustat given in a patient who has a high dose of myozyme of 40 every 2 weeks. We started gradually, stepwise, trying to see if the increase of those had any effect. But even with the stabilizer, once they increase the dose, we have noticed an important change. As mother, scientific evidence proven, I have none, but I have really seen that my child has improved as the time went by, where he was taking myostatin with myozyme. If you go over to the second generation, now I'm in the problem of, I don't know if this is very proven or not, but starting to prove it from the very beginning, a company, if I go over to the second generation directly, they are going to remove the miglustat, because it supposes it's better and has a greater efficacy and it is better in the muscle, or not. I don't know how to say that. I don't know how it's miglustat added to myozyme. There is no evidence to do that. So starting from that base, now they change the medication and give you one of second generation and give next myozyme. The idea would be not to add miglustat, because science says that it doesn't increase the benefit adding miglustat. And in the case that I have already noticed changes, even when we have to prescribe, we have to trust the studies that have been done with many patients, very rigorous studies. That's what we have to be based on, not on particular cases. When I have to prescribe, I wouldn't add miglustat to valglucosidase or myozyme. And the topic of the literature as to the increased dose in the patient, Is it enough supported that it says 40? Because my child is in childhood Pompe, but he is already 15 years old. And he's going and go over now to the adult hospital. And my medical guidelines say what they say to Pompe in general. My physician changed the dose because he saw a worsening in the child, so he increased that. But now I fear that maybe it's not well supported by the studies of with a specific case. And another physician comes and says, as miglustat is not supported, the dose of 40 is not either supported by the evidence. I'm going to ask, you can ask Javi, I will leave him to answer that question. Your child is 15 years and his child, but it's the severe form of the cardiomyopathy, or what was the diagnosis? He was diagnosed with at the age of 12 months, started the treatment. No, with 12 months they started making the test, and the treatment started when he was 16 months old, more or less. He had a large heart and muscle weakness. He has never been able to stand nor anything. So at the age of 3, he had a relapse caused by growth. He started having respiratory problems, and that's when they started increasing the dose. And after a long time increasing stepwise the dose, we started with miglustat, and both things have stabilized him exponentially. That's the truth. I think that one could say that it's an infantile form. So this paper could be useful for him as well. But of course, this depends as well on the autonomous communities, and it's a very expensive treatment if they want to accept that. The payer can say in the label that it says that, but we're not going to do anything else. Or if there are good arguments, maybe they do accept it. There may be differences between the different communities. Another thing is that when they go over to the next generation, to aval glucosidase, probably we have to reduce the dose, start with the lower doses, and always have the possibility of increasing the dose. I have seen people who have made the switch, and people who were with 40, they did the switch, and they changed to 20. I would have said that one should have to change to the same dose, and I have doubts in that respect. And when we make the change, let's see how this change is going to be done, the changing of the dose. Yes. Thank you.
¿Puedo hacer otra pregunta?
May I ask another question? One more? Just one more? One more. Could I ask 2 short ones? Anticuerpos, can they change during the person's life? And if my son, he makes antibodies, and then should we again test to see if there's a variation or if he's okay? You should follow up the level of antibodies regularly, but they can vary. Yes, they may. And with a new treatment, if there is a new agent, should we also have a closer follow-up if there's a change? Yes, just exactly the same. And then I'm going to check that. And I think when you spoke about physical activity, in the case of my son, we're trying to get him to be Rambo. So he's always doing things, physiotherapy, swimming, and passive exercises. I think we exhaust him at the end of the day. I recognize that. But at nighttime, he just falls. He's so tired. He doesn't really walk much, but he does do moderate exercise. Do you think this is counterproductive? Because I see him so exhausted at the end of the day. Answer: you should maintain physical activity of a certain intensity, but he should never be extenuated. I think that if he's exhausted by the end of the day, you should let him rest sometimes. Okay. But I'm not destroying muscle, am I? Something's not going well. It's like with athletes. Yeah, sometimes you have to lower the level. Yeah. Thank you.
Bueno, dar las gracias a...
Well, thank you, Nuria, Christine, and Javier. Don't leave. I have a little detail for you. And now we're going to have 15-minute breaks, and then we shall begin the second part of our meeting, where we are going to speak about, a quarter of an hour, we're going to speak about gene therapy. Thank you.